Hi there. My name's Diane Hurd. I'm a psychiatric nurse from Billings, Montana. I work at Billings Clinic. I've been a psychiatric nurse for the last 16 years, and most of that I've been working with kids and adolescents. I do work some on the adult unit, and I'm also involved in nursing research. Most recently, I'm the co-principal investigator on a pilot study for a non-pharmacological intervention called triple chronotherapy. And triple chronotherapy can be used to treat depression by using sleep phase advancement, sleep deprivation, and bright light therapy. It resets circadian rhythms, and we've seen some amazing results. So I've kind of become a research nerd as well. I am in my second year of the PMHMP program, and I'm having a great time, enjoying it a lot. So I know we're supposed to be discussing something that's an essential theoretical framework to our nursing practice. I guess the other day, a patient paid me what I thought was a high compliment. She was standing at the desk and she said, "You never make me feel like you're talking to a mental patient. You just treat me like a person." And for me, that's key. I want to bring respect to the nurse patient relationship. I want to encounter the person as a person, not as a diagnosis. If I'm setting a limit, um, I want it to be about a behavior or policy, not about the person. And I think that even the smallest child or even an elderly person who has dementia can perceive when someone is treating them with respect and will know when someone is being judgmental or patronizing. So that's number one. I want to come to that relationship with respect. Um, I didn't know too much about nursing theory until I finished my undergraduate degree, and then I had a chance to encounter some nursing theory. And one theorist that does work in psychiatry was Hildegard Peplau, and she talked about the nurse patient relationship and describes the phases of those relationship. And that was really helpful to me because it described kind of what I have always been experiencing, and helped me to see what was happening, and also maybe helped me to improve that process a lot. So Peplau talks about four phases. She talks about how there's an orientation phase with the patient, there's an identification phase with the patient, a working phase of the relationship, and then a termination phase of the relationship. But she describes those phases, and I guess how that applies to me is, when I leave report and come out onto the floor and meet my patients, that orientation phase, I'm setting up kind of, the boundaries in that relationship, but I'm also trying to be fully present to another person and to ask questions and listen carefully to what they're telling me. And I want to demonstrate to them that the follow-up questions that I ask, show that I'm listening carefully. And so gathering that information and kind of establishing that trust with them. To me, that's orientation. The identification phase is when we start to set some goals for the day together, that we are going to be working as collaborators. We're doing something at my hospital that I like a lot. It's a form that, I help my patient come up with questions that they have for their case manager, questions that they have for their doctor, questions that they have for me, and writing some of that stuff down so that they're participating more in that. As well. But they bring information, I bring information, and we prioritize it together and come up with some goals. And so that's identification, but then we're moving into what really is the bulk of the day, which is the working relationship, where we've set up what we want to do together in terms of goals, but then things start to get busy, and that's when I think that time management and understanding that I'm trying to establish some accountability and trust with my patient is so important. That's probably true with every patient, but I know for psychiatric patients, the minute they ask you for something and you blow it off or forget about it or didn't listen carefully, that can really damage that trust or that therapeutic alliance. So I'm careful right away to, when I gather that information, take some of that and try to follow through on some of the smaller things I can take care of right away, and to be checking back in with my patients, on progress on the things we've talked about and completion on things we've talked about, so that they know that I'm working with them at all times. And sometimes it's just doing that little thing. Oh, you're out of toothpaste, or do you need a cup of coffee? Those type of things really start that foundation of trust in that working relationship with the patient. People feel heard. People feel like they matter. I try and put myself in their shoes. Um, what would I be like if I was in this situation? What would I need? And then last, the termination phase. We don't do long admissions, it's 3 to 5 days. So basically, I start to talk about, well, what will you need to do when you leave here? And how can you problem solve these things when you leave here? And we talk about, those things, and that's kind of moving towards that transition phase. I try to be really present if they try and tell me, how I've mattered to them. I try and be present to that, but professional at the same time. But I think that helping them to think ahead about discharge is probably the most important thing I do in that transition to termination. So that was a little bit about me and what I do. Thanks for listening.